All right, engineers, so we've already talked about a lot of these things like pathophysiology, our causes, our clinical settings. We talked about signs and symptoms in another video. If you guys haven't seen that, please go see that before we get into this diagnostic workup, okay? So we're gonna get started here, and what we're gonna try to do is we're gonna have some stuff on the whiteboard, and we're also gonna kind of show you what we would actually be doing in a patient care setting. So we're gonna try to put all of these things on the board into action, okay? So first thing that you would be doing is you're going to inspect the patient. There is a method to the madness, right? So we start off always with an inspection of the patient when we're doing our physical examination. So again, we're going to start off first with a physical exam. We're not going to do a complete physical. We're just going to do our focus oriented, right? Which is going to be on the complaint that they're coming in for. So the first thing that we should be doing in the physical examination is inspecting. Right? That's the first thing that you always should be doing, is inspecting the patient. Now, upon inspection, what are some things that you would generally see with a patient who maybe be showing signs of typical pneumonia? We already said increased respiratory rate, right? So they could be showing signs of increased respiratory rate. Now, with that increase in respiratory rate, here's something that you might see. When someone's really having a hard time breathing, they start to utilize accessory muscles. And so sometimes you might see that they're having some accessory muscle use, sternocleidomastoid, maybe the pec major or minor. So you might see some of those muscles getting utilized in that sense, or scalenes. So you might see, with this increase in respiratory rate, a accessory muscle use. Another thing is sometimes whenever they're really having a hard time breathing, they can have what's called intercostal retractions. So you know how we have the ribs? Well, sometimes what happens is the muscles get pulled in. It looks like they're sucking in. That can be another sign of that they're having a really hard time breathing. So you can even see what's called intercostal retraction. Another thing that you might want to see, and I forgot to mention it up here, is they might have what's called a pleuritic chest pain. Okay, and it means that there's inflammation of the visceral and parietal pleura, and they're rubbing up against one another, and there's a lot of friction. And it can cause a lot of pain whenever they're taking breath in. So they might even say, I've been having some pain. Whenever I try to breathe, I have pain. And that could be signs of a pleuritic chest pain too. So you might even see that upon inspection as well. You might have them saying that they have some type of pleuritic chest pain. Okay, and you can get that from your review of systems when you're doing your medical history as well. Now, second thing that we need to go into is we go into particularly the palpation. So we're going to go into a palpation aspect. So whenever you're doing palpation, one of the big things is you're going to start off with what's called respiratory expansion. So I'll show you guys what that means when we get our patient Jeff in here, but we're going to see something with the respiratory expansion. So what we do is we try to take our hands in their back, and we try to have them take a deep breath in and then a deep breath out. What we look for is we look to see if our hands are moving symmetrically, or if there's a delay or a decrease or very little movement. Seen in classic like lobar pneumonia, whenever they take a deep breath in, one hand goes really well, but the other one lags behind. So that's something that you might see with someone who's exhibiting signs of lobar pneumonia, is a unilateral decrease or delay in chest expansion upon inspiration. So that's one thing that you might see. You might see, particularly again with lobar, you might see a unilateral decrease in the actual chest expansion. Another thing that goes on with the palpation is you're going to do we're going to talk about tactile fremitus. Okay, so we'll talk about this. Tactile fremitus. All you're doing is you're taking the palmar aspect, the hypothenar aspect of your actual palm, and you're going to radially deviate your wrist, and you're going to put these aspects of your palms onto the patient's chest or back. When you're doing that, you're going to have them say like a phrase, like classically they use 99. What that does is that determines lung tissue density. If someone has pneumonia, they have consolidation, fluid, proteins. What do you think it's going to do to the actual density of the lungs? They're going to be heavier. Well, air travels faster in water or fluids than it does in sound. So whenever you do that, you're going to have larger vibrations or more vibrations that you'll feel on the actual palm of the hands as compared to someone who has normal lung parenchymal tissue. Okay? So something you'll see with a tactile fremitus is they'll show signs of increase tactile fremitus. So that's what you would do with palpation. Now remember, these physical examinations is important, but they're really good, but they're not as sensitive or specific as compared to other diagnostic tests like chest x-ray, but they are important to do. Next thing with palpation is you go on to your next step, which is percussion. So we're going to go on to percussion. Now with percussion, here's the important thing with percussion. It is a good thing to utilize, but you're going to be taking and using what's called your plexor finger. I like to use 2 fingers, and your plexometer finger, which is your 3rd digit. And we're going to be tapping on specific areas of the chest wall, anterior and posterior, and we're listening for particular sounds. Like, for example, there's resonance, there's what's called hyperresonance, there's a flat sound, a tympanic sound, a dull sound. Dullness is what we're generally listening for, and what dullness signifies is that there's a lot of fluid within the actual lung tissue or the tissue spaces. Now percussion is interesting. Whenever you're doing that, if you're doing it well, it only penetrates about 5 to 7 centimeters beneath the chest or posterior back surface. So sometimes it can miss some deeper lesions. Okay, but again, with percussion, what are you listening for? You're listening for some dullness to percussion. Okay, so that's important for that guy. Now the next thing we go to is we listen for auscultation. Okay, so auscultation is going to be the next thing that we do. So auscultation is what you classically see with someone's bringing their stethoscope, they're putting their stethoscope on their chest, and they're moving it around, right? And they're listening. What you're listening for is you're listening for normal breath sounds. There's what's called bronchial, there's tracheal, there's vesicular, and then there's bronchovesicular. Vesicular is a normal breath sound. All of them are normal breath sounds. It just depends on where you're actually trying to listen for them. Tracheal, here. Bronchial is usually on the manubrium where you would hear those sounds. And then bronchovesicular is usually first, second intercostal space, anteriorly, and then interscapularly. But vesicular is generally heard throughout the entire lung tissue, the parenchyma. What you hear with someone when you're doing auscultation is you hear really harsh, loud, tubular sounds in their lung parenchyma that you should not normally be hearing. What is that? That's bronchial breath sounds. So upon auscultation, you'll hear bronchial breath sounds, and here's where it gets gooder. All right? You have adventitious sounds. What does that mean? Adventitious means it's a sound it's added on, or it's superimposed onto your normal breath sounds. So for example, I can hear my normal breath sounds, but on top of that, I'm going to hear sounds like I'm ripping Velcro apart. And that's called crackles or rails. So sometimes if someone has pretty bad pneumonia, you can also hear what's called crackles or rails. And it literally sounds like Velcro is being ripped apart. And that sound is because of the fluid in the alveoli and in the bronchial tissue. And whenever you're trying to inspire, you're trying to pop those actual bronchioles open, and it's producing that crackles or rail sound. And there's also different types, coarse and fine. All it is fine is usually a shorter duration. Coarse is usually a longer duration. Coarse is also a little bit louder, and fine is a little bit softer. But it's obviously indicative in saying that, right? So bronchial breath sounds and crackles or rails. There is another one they can hear, rhonchi, but rhonchi is not always seen. Sometimes you can hear rhonchi in atypical pneumonia, but generally the main one that you'll hear is your crackles or your rails. Okay? Now, the last thing here for the physical examination is your special tests. These are called your transmitted voice sounds. And again, you do this with auscultation. And we're going to show you these. You're taking your stethoscope, you're putting it on the patient's back with their hands across their chest. And you're doing 3 tests. You don't have to do all of them. You can only do 2 if you like, but they're called bronchophony, egophony, and whispered pectiliquy. Bronchophony is you're basically having them say 99. And whenever they say 99, it shouldn't be very clear and distinct. If it is, that means that there's a lot of fluid. That means that the sound is being transmitted better. That means you can hear it better. There's signs of consolidation. So it would be very clear and distinct whenever they do bronchophony. If you do egophony, it's generally you're having them say E, but whenever they say E, it should be kind of very soft and muffled. If you hear E to A or Ah, then that is a sign of consolidation. And again, a lot of increased lung tissue density. That could be another sign, and that's called egophony. And then whisper pectiliquy is you're having them sit, like very whisper, like very slowly, like very softly, 1, 2, 3. And whenever they're doing that, if you can hear literally so clearly and distinctly the 1, 2, 3 over their whisper, that's a positive whisper pectiliquy. All of these things are signs of increased lung tissue density or consolidation. So some things that you'll also have is they'll have what's called positive egophony. They'll have positive bronchophony. So then also they'll have a positive sign of what we just talked about, whisper pector eloqui. Okay? So those are things that we'll see upon the physical examination. Now, we're also going to, like I said, these aren't as specific and as sensitive for being able to diagnose. You can't just say, oh, this is it, we're going to give them antibiotics. No. You have to go through, do some other diagnostic tests. We'll talk about chest x-rays. We'll put some chest x-rays up and we'll have us point to the classic ones, broncho, lobar, interstitial, or also called atypical. And then we'll talk about some lab stuff that can come up as well. But before we do that, what we're going to do is we're going to switch over gears. We're going to do something a little bit different, and we're going to use a patient now to kind of show you what we would be doing. All right, engineers, so now what we're going to do is we're going to go over a physical examination. This is going to be our patient right here. His name is Jeff. We appreciate him coming in and doing this for us. So we're going to try to mimic what we would be doing on a physical examination. The reason why we want to do it is you can read these words and maybe not understand exactly what the test, like what you're actually doing. Now, obviously, Jeff is a very healthy guy, so some of the things that you're going to see are not going to be the signs that you'll see on the board. But again, we just want to give you an idea about the techniques and just put some action to the words that you see on the board here, okay? So what I'm going to do is I'm going to begin with this physical examination. I'm going to wash my hands, and I'm going to have Jeff take his shirt off so we can expose the entire lungs and thorax, okay? Look at this dude, he's ripped. All right. So the first thing we're going to do is we're going to be inspecting the lungs and the thorax. And when we're looking at it, again, what should you be looking for? Looking for any accessory muscle use, looking to see if his sternocleidomastoids are being utilized, his scalenes, any of his pec muscles. You're looking to see if there's any intercostal retraction. Again, you're trying to look for his respiratory rate, the depth of his breathing, if it's heavy, if it's rapid. Another thing that you could be doing here, again, going along with some of those abnormalities, is looking at his anterior-posterior diameter. Sometimes you can have patients who have barrel chests, and they have an increased anterior-posterior diameter, and that's indicative of COPD. You also want to look to see if they have any thoracic kyphoscoliosis, maybe any type of pectus excavatum or pectus carinatum as well. These are things that you could be looking for upon inspection. But again, the big things that I want you guys to realize is look for any intercostal retraction, any accessory muscle use, look at the depth, the rate of his breathing, and if there's effort, okay? The next thing we'll move on to is palpation. So what I'm going to have Jeff do is I'm going to have him flip over. I'm going to have him expose his back here. Now what we're going to do with this rip dude here is we're going to come about to the belly button level. And remember, I told you that you'll come here, okay, about the level of T10 here. I'm going to pinch about right there. Now what I'm going to have Jeff do is I'm going to have him take a deep breath in, and then I'll have him breathe out. Now, if you noticed, my hands moved symmetrically whenever I had him do that. What would be something abnormal? Don't worry about it. I'm going to show you right here, is when he would take a breath in, this hand would move this way and this one would delay. And it could be indicative that he might have a lobar pneumonia here in the left lung. Okay? So that's one thing that we would see, is we would see a unilateral decrease or delay in chest expansion. Okay? So that's one thing we would see. The next thing we would do, he's already having his posterior back exposed. But I want, right now, his lungs are blocked by his scapula. So what I'm going to have him do is I'm going to have you hug yourself. All right, perfect. Now, that kind of pulls the scapula away a little bit. What we're going to do now is, remember, tactile fremitus. We're going to take the hypothenar surface here, and we're going to go ahead and push down. I'm going to push onto him a little bit there. I'm going to have you say 99. 99. And I can go down a little bit lower, 99, say it again. 99. What I'm feeling for is an increased frequency or transmission onto the palm of my hand there. If it is increased tactile fremitus and I literally feel it very, very strongly, it could be indicative of increased lung tissue density. Okay, and I'd be doing this the same thing on the anterior surface as well. All right? The next thing we could do, since we already have Jeff's posterior back exposed here, we could do the next thing, percussion. Now, when we do percussion, there's a bunch of different ways that you could do it. What I was taught is, again, I'm going to have you cross your arms again, Jeff, so we can pull those scapula away. What you could do is you want to make sure that you cover the entire lung field, okay? When you're doing these, make sure whenever you're doing tactile fremitus, cover the entire lung field. And don't just do down the midline. Do the lateral sides as well, okay? When I'm doing percussion, I want to start kind of higher up here because the lungs come up above the clavicle, about 2 to 4 centimeters above the inner third of the clavicle. So when I'm doing percussion, I want to kind of start up high here. And like I said, I'm going to use my pleximeter finger, my third digit here. And I like to use 2 fingers. And when I'm doing this, I'm tapping, okay? I'm tapping here, and I'm listening for the sounds. Generally, what I should be hearing is more of a resonant, kind of a low pitch, slightly loud, longer duration sound. All right, so again, what we'd be doing is we'd be percussing. So for example, if I was doing this, I would do a ladder technique, right? So I would start here, I'd come across, come down, come over here, and I would just keep working my way down, and I'm listening for sounds, right? Now, with someone who has pneumonia, they're going to have a dullness, okay? Now dullness, here's one thing that you could compare. So Jeff, I'm going to have you lay down on your back here. The liver usually presents with a very similar sound, dullness. All right, so now what we're doing is we're going to be comparing. So I want to give you an idea of what dullness would generally sound like. Now tympanic you would hear over here. And so I'll give you an idea of what tympanic should sound like. So this is where your stomach is in the left upper quadrant. So listen here. That's tympanic. It sounds hollow, drum-like, right? Pretty loud. If I'm doing liver, the liver is pretty dull, okay? So if I'm doing this one, you can tell that's a completely different sound, right? That's generally what you would hear with someone who is having signs of pneumonia. There's a lot of fluid there, all right? Tympanic, if you heard that in the thorax, you want to be careful. That might be a pneumothorax. There's also flatness. Flatness is usually a sign of like a pleural effusion. And then you can also hear something which you refer to as hyperresonance, and that you can see in situations like COPD or asthma, okay? So again, one thing that you'll listen to whenever they have percussion is you're going to hear dullness. And again, if you want to have something to compare the dullness to, you can listen to it here around the liver. So again, I'm going to give you that one more time, and then we're going to do it on the back, and you're going to be able to tell the difference. Because on the back, you should hear resonance, normal lung parenchymal sound. So I'm going to do it again one more time here for the dullness. Okay, and I'm going to have Jeff, I'm going to have you sit back up again, facing that way. And again, giving you an idea here, this is a completely different sound. This should be resonance, it should be normal lung tissue here, okay? So again, giving you an idea here, should sound different, okay? And again, it's a subtle difference. It's sometimes very hard to identify, but that is some diagnostic tool that you should have with you. Again, listening for dullness to percussion. So far, we've seen that if we have lobar pneumonia, there will be a decrease or delay in chest expansion during inspiration. They'll have an increased tactile fremitus, but again, I can't stress this enough. Make sure you cover the entire lung field, not just down this way, but laterally as well, and doing it on the anterior surface. And when you're doing it, having their hands on the posterior surface, having them hug themselves. When you're doing anterior surface, have their hands on their hips. Again, we said that you'll have dullness to percussion. What could dullness sound like? Compare it to the liver, okay? The next thing that we'll be doing is auscultation. We're listening for breath sounds. Now, obviously, you guys aren't going to be hearing this, but I'm giving you an idea of what you should be doing. When you're auscultating, you want to make sure that if you're doing it on the posterior surface, you have, again, their arms crossed over. Can I have you cross your arms, Gio? Okay, and then what I'm going to be doing is I'm going to be putting the diaphragm of my stethoscope on his back. Every time I do that, I want him to take a deep breath in and a deep breath out. And I'm going to be listening for the duration of inspiration, expiration, and I'm going to be listening to the pitch. I'm going to be listening to the intensity. If someone has pneumonia, I'll hear a very harsh, hard, and even tubular high-pitched sound in their normal lung parenchyma. And that is not a good sign. That's usually a sign of pneumonia. Another thing that I would hear as I'm auscultating is I would hear Velcro, like it sounded like Velcro is being ripped apart. And that's going to be your crackles or your rails. So again, how would I be doing this? If I'm showing you, all right, Gio, every time I put my stethoscope on your back, I just want you to take a deep breath in through your mouth and out through your mouth, okay? Okay, so if you followed that ladder technique, we went all the way down. We tried to cover the entire lung field. Remember, you're doing posterior and lateral. You'd be doing the same thing on the anterior surface. It doesn't matter how many times you do it. There is obviously a technique, but as long as you're covering the entire lung field, that is the important thing. Now, if you have an older individual, you got to be careful because they're not going to be able to do it that fast. You're going to have them pass out on the bed right next to you. So make sure that you take that into consideration when you have an older patient, taking your time and just listening very well. Okay, another thing that we do, again, is we'll do some special tests, the transmitted voice sounds, right? And it's very similar. What I'm doing is I'm going to be doing the same pattern, but as I'm doing it, it's this exact same thing, the exact same pattern that I just went through. All I'm doing is, on every single spot, I have him say a different thing. For example, we're not going to do all of them, but I'm going to show you what we would do for a couple of them. We're going to start off, Gio. What I'm going to have you do is I'm going to place my stethoscope on your back. Every time I do, I'm going to have you say 99. Okay? This is testing bronchophony. So what I'm going to do is, okay, go ahead.
99, 99. 99, 99.
And that's bronchophony. What I'm hearing is a very muffled and indistinct 99. If I heard very clear 99, that'd be signs of consolidation, increased lung tissue density. The next thing I would be doing is egophony. Every time I put my stethoscope on your back, I want you to say E for me, okay?
E, 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 E. E.
And again, with that, what I'm hearing is a very soft and muffled kind of E. If I heard a very E to A conversion, that's where you got to be careful. E to A or E to Ah, that is going to be a positive egophony. And again, consolidation, increased lung tissue density. The last one I'm going to have you do here, Jeff, is we're going to do whispered pectiloquy. So what I'm going to have you do is I'm going to have you whisper for me 1, 2, 3, very, very softly every time I put my stethoscope on your back here, okay? And again, I shouldn't be able to hear it very clearly and distinctly. If I do, that's again a sign of consolidation or increased lung tissue density. So I'll give you here another example of that. Okay, ready, Geoff? And again, it should be very indistinguishable. It should be very hard to identify. If it was very clear, again, that would be a sign of increased lung tissue density. So these are the things that we would be looking for upon the physical examination. I'm going to have Jeff flip back around here. So we're going to be doing the same thing. Everything that we did on the posterior aspect, you're going to be doing on the anterior aspect, except for the special tests. Again, that whispered pectiloquy, egophony, bronchophony, you only are going to do that on the posterior aspect. But again, anytime you're doing something on the posterior aspect, make sure that they're moving their actual scapula out of the way by crossing or hugging themselves. When they're doing it anteriorly, Jeff, what I'm going to have you do is I'm going to have you put your hands on your hips there for me. So it's opening up, so whenever I'm palpating, if I'm palpating here and here and here, I can also come here and palpate, 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 and feeling for any pain or tenderness and looking for any areas of petechiae, right? When I'm percussing, I'm doing the same thing, but always start here above the clavicle. 2 to 4 centimeters above the inner third of the clavicle is going to be the actual apex of the lung. So whenever you're doing it, you're percussing there. Same thing, comparing it. You want to make sure that whatever you're doing, you're comparing bilaterally. That is the significance here. Whenever you're percussing, listening, doing anything, compare it bilaterally. So if I'm doing it here, I want it to sound the exact same over here. Okay? If I'm coming over here, I want it to sound the exact same over here. Okay? Next thing, if I'm doing auscultation, I'm comparing bilaterally. So what am I doing? Again, auscultating, I'm listening for vesicular breath sounds. Those are your normal breath sounds. What should I hear if someone is showing signs of pneumonia, bronchial, very harsh, very tubular, very hard, high-pitched sounds? And again, how am I doing it? Make sure that you follow that same pattern. So for example, again, Geoff, every time I put my stethoscope on your chest, I just want you to take a deep breath in through your mouth and out through your mouth. We're going to do a couple of examples here. So start up here. Go ahead. And then make sure you compare bilaterally. And you come down here and compare bilaterally. And again, what you should be doing is comparing bilaterally and always seeing if it sounds any different. What should you hear if someone is showing signs of pneumonia? Bronchial breath sounds. What would they have to percussion? Dullness to percussion. What adventitious or added sound would they have? Crackles or rails. What would that sound like? It literally sounds like Velcro is being torn apart. So you would hear that. And now again, egophony, bronchophony, and whispered pachyliquy, you do this on the posterior surface. Okay? So that's what we'd be doing on the physical examination, just to give you guys an idea of putting these words to action. Okay? So I want to give a great thanks to Jeff here for doing this for us. We appreciate it. If you guys could give him a good thanks in the comment section, we would appreciate that as well. Thanks, buddy. All right, guys, so we went over our physical exam. We went through it on the board. We went through it with Jeff as our patient here, giving you guys an example of what we were writing on the board. And if you're wondering why this is so much more beautiful, it's not my handwriting. We had Kristen, one of our team members, come up and help to fix this up. So we have some more room to put down here in the diagnostic workups. So again, we went through the physical exam. What's another thing that we're going to do? Okay, well, we are suspecting pneumonia. We're going to want to send them for a chest x-ray. Okay, so we'll do a chest x-ray. So now, what we're going to be doing here is we're going to mention something here. For the chest x-ray, sometimes you'll see it as CXR, we're going to be seeing three morphologically, now this is the classic, three classic morphological or anatomically different types of pneumonia. There is many other. We're going to go through the most common, okay? Now, what are these? So the first one, and we talked about this a lot with the pathology and all these other things that we talked about with the physical exam, classically is going to be your lobar pneumonia. Now, this is the one that shows that consolidation, and that's where you have a lot of that alveolar exudate, maybe some white blood cells and some proteins and some fibrin, and if there's damage to the pulmonary capillaries, even red blood cells there. Lobar pneumonia usually shows, as it would say, in a lobe, a right middle lobe, a left upper lobe, a left lower lobe. These are one of the classic ones that you'll see, and we have some x-rays that will show you what you would see this in. The next one is going to be bronchopneumonia. Bronchopneumonia. Now again, going real quickly back to lobar pneumonia. Lobar pneumonia, just remember, it's classified with consolidation of the alveoli and some of the associated bronchi. Bronchopneumonia is going to have these, it's diffuse, it's patchy, it has reticular, which are like lines, and reticulonodular, like little dots, little white opacities that you're going to see on the chest x-ray. And they commonly present at the base of the lungs. Okay, so this is bronchopneumonia. The next one, and the final one that we're going to talk about here, is going to be interstitial pneumonia. So interstitial pneumonia. This is also called atypical pneumonia. Now, interstitial pneumonia, usually, you can read it within the word, it's where the infection or the inflammation is in the interstitial space between the pulmonary capillaries, in the alveoli, and the surrounding bronchioles. That's interstitial pneumonia. Now, this one also is diffuse. It's also patchy, but it's primarily reticular. And another thing that we'll see on the chest x-rays is that primarily this reticular and diffuse patchy pattern is primarily perihilar. which is right around the hilum of the lungs, where the pulmonary root, the pulmonary artery, pulmonary veins, your primary bronchi, your nerves and lymphatic vessels are going in and out of the lungs. And you'll see that, okay? So again, we'll talk about things that you can see on the chest x-ray that is important. Other things that you might see is sometimes, particularly with Klebsiella, there's another sign you can get what's called a bulging lobe. You can get some cavitations. There might even be abscesses that you can sometimes pick up as well. But again, these are the 3 pneumonias that I want you guys to remember that can usually show up on the chest x-ray. All right, guys, so as you can see here, we're looking at a chest x-ray, and this is going to be in the posterior anterior sitting. And what you're looking at here is this is obviously going to be where the right lung would be. This is going to be where the left lung would be. This is going to be your right diaphragm, left part of the diaphragm. And as you can see here, this is going to be the heart with the right ventricle and the left ventricle, and then you can see the anterior right heart border. But more importantly on this is when we're looking at lobar pneumonia, classically lobar pneumonia presents with like this triangular presentation right here. So if I were to kind of point this out here, you would see I'm going to kind of point here to this edge, and then I'm going to point here to this edge of it. So as you can see here, we have in between these red lines here, we have this triangular shaped structure, and that's a sign of consolidation. And consolidation is very typical in individuals with lobar pneumonia. All right, guys, so we're looking at another chest x-ray here. We're particularly looking at bronchopneumonia. So bronchopneumonia is going to be patchy. So it's going to be patchy and diffuse, and how we describe it is reticular. So you can kind of see here, there's like these little squiggly lines, and they're kind of extending all out here, moving their way out this way, and some over here as well. So you're going to see this reticular pattern. Another thing that you might see here is not just reticular, but you might even see these like nodules there. So there's going to be this reticular or reticulonodular like appearance. And here's another like nodular appearance as well. So the big thing with bronchopneumonia is you're going to have this diffuse kind of widespread reticular or reticulonodular like opacities, which is this whitish kind of stuff that you see here. And another thing that is really important is most of the time, not always, but most of the time, bronchopneumonia is usually bilaterally. So you get it in both lungs, and it's more commonly seen at the bases of the lungs. So remember, bronchopneumonia, reticular, reticulonodular, diffuse, kind of scattered. You see it in bilateral, so both lungs, and it's more commonly at the base of the lungs as well. Okay, so that's bronchopneumonia. All right, guys, so now what we're going to do is we're going to go over the last type of pneumonia that I want us to take a look at here. And this is going to be interstitial or atypical pneumonia. Most commonly, you can see this with mycoplasma. We also said chlamydia, maybe even some Legionella as well. But this one's kind of similar to bronchopneumonia, except it is, again, kind of a patchy, reticulonodular type of opacities. But here's the thing. The reticular appearance that you're going to kind of see here is going to be more concentrated on the perihilar region. So if you can kind of see all of this right here, there's some nodularity there, and there's some reticular or these like line-like appearance. And if you notice, it's right around the heart borders or near this area of the hilum. Now, if you don't know what the hilum is, just a little bit of an anatomical presentation here, is the hilum is going to be where you have the pulmonary artery, the pulmonary vein, you have the right primary bronchus and left primary bronchus, depending on which lung you're talking about, your lymphatics, and even some nerves going in and out of the lungs. So right around this area is your perihilar region. And so what you can see sometimes, it's a tougher pneumonia to be able to identify, but you'll see some reticular or reticulonodular opacities that are primarily on the perihilar portion here. So right around this edge. But again, sometimes it is tough to be able to see. Sometimes you have to get other things, other symptoms and clinical examinations to really help to identify this one. But again, that's going to be interstitial or atypical pneumonia. Okay, guys, so we've gone over the chest x-rays. So now what we're going to do is we're going to move into the next thing. So we've done our physical exam. We've done our chest x-rays, and you can also do CT scans as well, but we're going to stick with the plain chest x-ray radiograph. And then the next thing you can do its utility is debated sometimes, but you can do what's called sputum cytology. So another thing that you could do is sputum cytology. And all it is you're just doing a gram stain and a culture. Okay? Now again, going back to this, sputum cytology, you have to send this to get gram stain or culture, but you can also get a kind of an idea. It's not perfect, it's not like a perfect thing, like, oh, that's it. But from a macroscopic appearance of the sputum, you can gain a little bit of an idea onto what kind of bacteria might be associated with this infection. What do I mean? So if I say that someone comes in and I notice that their sputum is rusty, like rusty or blood tinged, maybe have a little blood tinge to it. This is classically, not all the time, but classically seen in strep pneumo. A really, really weird one is sometimes it can look like the sputum can literally look like currant jelly, okay? It's jelly-like. This one, if it looks currant jelly-like, this is classically seen in Klebsiella. All right, and the third type, if you have their sputum and the sputum is really foul smelling, that's usually seen in anaerobes. So anaerobic bacteria, sometimes which could be from aspiration, from like the GI contents. The last one, and again, it's not always high utility, not always the most perfect thing to go by, but another thing that you can utilize is if it's green. So if it's kind of a green sputum. A green sputum is seen in Pseudomonas and maybe even Haemophilus influenza, okay? So you can do sputum cytology, you can take the sputum, send it out to get culture to do a gram stain, or you can do a macroscopic just view of it. If it's rusty blood tinged, strep pneumo. If it's currant jelly, Klebsiella. If it's really foul smelling, think anaerobes. And if it's a green sputum, possibly think Pseudomonas and H. flu. Okay, so these are the things that you'll do during your diagnostic workup, right? Something else to consider though, just some other small things is if you do blood work, you might notice that they have an increased white blood cell count, leukocytosis. Again, that could be indicative of an infection. Another thing is whenever people have signs of inflammation, usually you can do what's called an erythrocyte sedimentation rate. And usually they have a high ESR. And all that means is erythrocyte sedimentation rate is a good sign of non-specific inflammation. And so the red blood cells, they actually move to the bottom of the test tube at a faster rate because of some condition that's increasing the fibrinogen production. Another thing is they might have a high CRP, C-reactive peptide. That's produced by the liver as an acute phase response protein. And again, signs of inflammation. So those are some things that you might get from their blood work. Also, their O2 sats they might be low because again, they're having a hard time being able to breathe and to saturate the hemoglobin within inside of the red blood cells. Other things that you can do, particularly for the atypical findings. Remember, mycoplasma, we said that you could see bullous laryngitis or pharyngitis. Another thing that you can do, they don't always do this, but you can send what's called serum cold agglutinins. Serum cold agglutinins is, what happens is red blood cells can have antibodies that attack them and cause them to agglutinate, clump, at cold temperatures. Mycoplasma pneumonia, for some reason that there's not complete understanding of, increases the agglutination of red blood cells at cold temperatures. So you can send serum cold agglutinins, and again, they'll show signs of cold agglutinin disease with that situation. Legionella, you can see again, GI upset, nausea, maybe vomiting or diarrhea. You can see increased liver function tests and hyponatremia. Another thing with Legionella is if you do a urinalysis, they might have a antigen, the Legionella antigens that show up in the urine. And chlamydia, you can do IgG and IgM titers to check that as well. But those are some of the other things that you could do in your diagnostic workup. Okay, so in this video, we covered all the different things about the diagnostic workup. We went through a physical exam. We used a patient to give you an example of that. We went through chest x-rays, and we went through some actual examples of chest x-rays and tried to identify the most common morphological presentations. And then we talked about sputum cytology and the macroscopic appearance of it, and we mentioned some other things in there, blood tests and other atypical things that you could be looking for as well. I hope you guys enjoyed this video. I hope it made sense. I really do. I want to ask you guys, if you guys could, please like this video, leave some comments down in the comments section, subscribe. Also, go check out our Facebook or Instagram account so we can keep in constant contact with you guys and figure out what you guys like and what you want us to do. Also, if you guys can, please go to our GoFundMe page that we have in the description box or our Patreon. If you could donate any amount possible, we would appreciate that. All that money will be going into equipment, into markers, into books, into editing software, everything that we can use to provide free videos for you guys' enjoyment. So again, I want to thank you guys, Ninja Nerds, so much, and see you next time.